Meet everyone. So I started Outbound AI in March of 21, spinning out of Providence Health System and their big for-profit revenue cycle platform that they were trying to build up called Tegria. And the goal was to see if we could develop AI-powered virtual agents that could do phone-based administrative work. And we felt like if we could build again, we called it a virtual agent that could make phone calls autonomously with machine learning, that there would just be a ton of applications in healthcare to bring efficiency and scale and reduce administrative burden. So we set out to build that technology both at a platform layer and an application layer, and our focus has always been around billing and doing payer-based billing work, so making phone calls out to payers. And today we are conducting hundreds of thousands of calls a month on behalf of revenue cycle management companies that serve health systems or serve practice groups, or in some cases we are working with EHR companies, particularly ambulatory EHR companies that have captive billing services divisions to process claims on behalf of physicians with payers. And in some cases, we're working with leading health systems to help empower their billing teams process claims with payers for both their hospital billing and their physician billing teams. And we do all this work by navigating the payers' existing language systems that they use. Because yes, EDI works for initial claim submission and initial adjudication, but today hundreds of billions are spent by in-house billing teams and outsourced billing teams all over the world to process these claims with payers because they pend with payers, they are denied, increasingly denied with payers, they're downcoded by payers, they're underpaid at the service line item level all day long, and it puts a tremendous burden on the billing administrative staff at hospitals and doctors' offices to try to make sense of it. And then finally, that's further complicated because there's all these payer types, large commercial nationals, regional blues, a ton of regional blues and regional blue plans, Medicare, traditional Medicaid, managed Medicare, managed Medicaid, and they all have different ways humans use language skills to somehow deal with the claims that require additional processing work. And so we're building out this payer intelligence layer that understands how to navigate using language to get the information from the health insurance companies.
Fascinating. And in your world?
Hi, well, my name's Evan Zaslow, and my role is Chief Managed Care Officer for City of Hope. And so in my role, I'm responsible for all of the contracts, the reimbursement, rates, terms, our network strategy for our system at City of Hope. And like Stead had mentioned too, it's a very complex area where you start adding the different layers of reimbursement methodologies, hundreds of contracts or more across a large system. It can be very, very complex. City of Hope in particular, it's a 113-year-old hospital that originated in Southern California in Duarte, started in tents treating patients for tuberculosis and ultimately shifted to focus on treating cancer and diabetes. City of Hope's the highest volume blood and marrow transplant center in the United States, the highest volume CAR T center in the United States. And for those cell therapies like CAR T, where the product costs alone or entire episodic cost of the treatment can approach $1 million, City of Hope is a pioneer in research where 1 in 3 of the CAR T treatments we did last year were done under a clinical trial. So not only giving patients access to the most advanced treatment, but also for a payer that's typically covered by a sponsor and it's free. So incredible value there. As far as AI goes, it's along the lines of what Stead had described too, that we're really in an environment where policies are continually changing with payers. We're managing an extraordinary volume of contracts that are essentially the foundation for everything that we do, and then trying to track on the back end, were we paid in accordance with our contract? So we've developed a variety of different tools to try to accelerate this and really focus on, from my perspective in managed care, I'm here to fund the mission. And our organization's a nonprofit, but at the end of the day, to deliver some of these advanced therapies, there is a cost associated with some of these products, and we have to ensure that our reimbursement is commensurate with the level of care that we provide.
I think one of the worst words in the English language is denied. And you probably mean something a little bit more specifically for each of you. You mentioned the word and the chaos that causes. Could you speak a little bit to how your work is hoping to minimize the denial or the impact of the denial?
I'd say for now our focus is on the impact of the denial and all the subsequent downstream work that hospital staff, billing staff have to do once that happens. And the problem as you dig into the maze of this thing is there's multiple levels of denials. There's the claim level denial, so the full claim where there's multiple service lines submitted, or then there's service line level denied. And those are rendered paid most of the time as paid. And you have to double click into the package to know that certain service line items have been denied. And so a big portion of the bill to the payer can show up initially as paid in the claims adjudication, but only do you realize that a few service line items have been denied by the payer. And so that creates more research and work and triage for teams to account for that and understand whether you're going to appeal it or try to how you're going to handle that, including down codings, which is happening now too. And so the payers are now allegedly, and I think in practice, are using more AI to deny more claims at the top level or at the service line item level or down code, which creates more obligation on the billing teams to be able to double click and make sense of what's happening here more and more. I'll just say that the big trend right now that where people have used AI on the RCM or health system side is automated LLM-based appeal letter generation. And in the past, there would only be a threshold of charges that were denied that you would write an appeal letter. And increasingly now they're using LLMs because the cost to write an appeal letter is now basically zero. So they're appealing everything, submitting the appeals auto-generated, and then sending them all out for all denied claims. And then that's overwhelming the payers. And it's also overwhelming the teams, the billing teams, who now have to follow up with this massive volume of appeals, and that's impacting you guys on the managed care side, because now you have more, in theory, total appealed claims you can negotiate with the payer on. And so so his teams are now being able to go and say, we used to only appeal 10% of our total denied claims. Now we're appealing 90%. And the dollar volume is massive, and it gives more ammunition to negotiate.
You know, Evan, I in my opening this morning, I talked about what Jeffrey Hinton said when he accepted the Nobel Prize for AI, and basically the importance of using it for efficiency and the good of mankind in healthcare. And it seems like, the analogy I thought of immediately with you is sort of your drugs and what you're giving those patients in a specialized setting is sort of the precious quarterback, and it seems like you're acting as the pulling guard, to let him do an end run. But what is it really that is your day-to-day, and then I'll get to data in a minute, but what is it the day-to-day that you try to, like 2 or 3 major problems that you try to address in giving those specialized therapies? Because those patients are special.
Sure. So the top areas where we try to ensure that we don't have interruptions, the first thing is on the front end. For many of these specialized treatment, there's a prior authorization that comes with it that we need to get permission from the health insurer or managed care organization that we're working with to deliver that therapy. And sometimes that can create bottlenecks for us to where either a patient is waiting or there are other obstacles within their plan that are preventing them from getting the surgery that they need or the drug regimen that they need. So in managed care, a lot of times we act as firefighters that every day we have a litany of issues that are coming in, and especially operating in a larger health system or a multi-state environment, it can be coming in from every area, whether it's case management, whether it's revenue cycle and authorization-related issue, denials. And so what we've tried to leverage with and built with AI was wanted to have a single point of entry for all of those issues and focusing on digitizing all of our contracts as well as payer policy that ultimately using a large language model, we could integrate everything together to where when our team goes to contest those issues or work through in a joint operations committee with our payer, they're equipped with a script that allows them to understand that here is what the contract says, here is what the policy is, this is the specific issue, and here is the reason why this should have been approved or authorized or we should have been paid for this. So trying to make ourselves effective at supporting the mission to ultimately provide that care to those patients who need it.
Yeah, and then you know, in the little exchange we had before this, you talked about, I could ask this question to almost every single speaker, you know, data are the new oil, the new gold, whatever. Everything that you need to do involves data. So not so much the blood, sweat, and tears, but what are the biggest issues you face? And have you had wins that you can share, and how do you address them? And we'll go to you next. Yeah.
Sure. So from a data perspective, on the managed care side, typically our team isn't necessarily working on clinical care for a patient. We're trying to work on the operational side or analyzing financial data to try to make some type of strategy or conclusion based on it. So the biggest issue for us can sometimes be disparate systems, disparate locations, data integrity to where we're relying on data or even in some cases using AI, there can be AI hallucination or other issues to where we get to a conclusion that isn't the reality of where we need to go. So for me, I think the biggest issue is trying to focus on that we have appropriate buckets and appropriately managed data to get us to where we need to be.
Yeah, I think it's the big last mile issue in AI is data normalization, data pipelining, data optimization from our customers to us. And certain enterprises have better structured data and data systems that make it easy to normalize, and others have more complicated environments. And that's really the huge sort of friction point for applied AI adoption by the enterprise and capitalizing on the ability to drive scale and ROI. So I'd say that's a big one. The other area where data, you probably always heard about that one. That's a huge problem in healthcare. And ultimately services is going to have to be added to kind of help these teams because most of the healthcare enterprises are not staffed appropriately to do the data normalization, data optimization work. And so there's got to be some sort of service layer that comes in and gets funded to kind of get that going. So truly AI gets adopted in the healthcare enterprise. The second piece where data management is really important is auditing. And I think you alluded to kind of the hallucination front. I mean, you're constant with your customers in a ongoing iterative data process, data expansion, payer expansion, growth and scale process of driving AI through the enterprise. And that's ultimately a constant data normalization and data auditing process that keeps going. And so generally as an industry, I don't think we're particularly staffed or skilled to do that work. And that's why, although we're seeing really good early results with top decile customers who have really clean data, for some customers, they struggle because of the data environments that they're dealing with.
Yeah. The other aspect is both of you, I would think, would have maybe parallel but different views on return on investment. You're investing at some point to get your tools going. You're trying to make things happen. So maybe you can go first, and then you can follow on how that might work. If we have time, we'll get into governance, but we'll see.
Sure. So from my perspective, too, especially dealing with, in my space, a large health system, high dollar claims, it's an incredibly large amount of revenue that we're looking at. And if we can use and leverage AI to either, strategize and determine how we're going to approach, what we're going after, like I had mentioned with the issue resolution tactics that we had, or two, organize the data to try to figure out what claims, what balances erode, what claims are due to us. On that end, it becomes really easy to make a material return on investment. So when we're working in the billions of dollars, if we can make a 1% improvement across the board, it's measured in the 8 figures. And so from an ROI perspective, it's incredible of what we're able to impact from a managed care perspective.
Oh. Well, and then maybe we can just turn to the last question before we break, and that's in the governance issue. So what do you feel is the biggest, there's rules and regulations out there by various organizations. Which ones impact you the most? Let's ask you both to answer that question before we break.
The probably more obvious one is in AI review boards, the issue of LLMs and hallucination is a big issue. So outside of that, and we use narrow language models, so we kind of get around that safety issue. Outside of that, I think the biggest governance issue that we're facing going forward is the need for technology teams to embed into the customer locations more in order to facilitate. So that's a services, you're going to need tech vendors, teams, inside the 4 walls of the healthcare entity, partnering with their teams, IT, to actually data normalize and data facilitate. And I think that's where it's probably going. And so you need to authorize our people to be embedded in your systems, and that's a big next step for the industry.
Yeah. And from you, is the governance?
I think pretty similar. A lot of the areas from that hallucination perspective, we always have to ensure that AI is a co-pilot or tool to get us to where we want to be. But on larger decisions, it needs to be validated. And another big area that we deal with at times too within our organization, we have an AI governance committee. But dealing with HIPAA and ensuring that if we're looking at patient data that includes protected health information, we have to ensure that it's safeguarded appropriately and goes through all the proper channels in our organization. And sometimes what I envision of what I'd like to do doesn't always align to the security protocol of our organization.
I'm a visual person, and I kept having this vision of raking spaghetti. It's an interesting world, right? Well, I'd like to thank you, and I'll make sure that all of you have the chance. This is intentionally a rapid-fire podium, but the intention is to be able to have time in all of the breaks, and there's facilities to have breakout sessions and to learn more from Steed and Evan, and I'd just like to thank you very much. It was awesome.